Good morning everyone, I am Christian Justin Acosar. Today I'm gonna report a patient classification system. So patient classification system is defined as the categorization or groupings or patient according to an assessment of their nursing care requirements over a specified period of time. Patient classification system is a means of categorizing present patients according to the care needs that the nurse can clinically observe. Next is purpose of patient classification systems or PCS. First is staffing. The system will establish a unit of measure of nursing time. This unit for measure will be used to determine both the numbers and kinds of staff needed. Perceived patients can be matched with available nursing resources. Second is program cost and formulation of the nursing budget. A prescribed unit of time will be used to determine the actual cost of nursing service. Third is tracking changes in patients' care needs. A PCS gives nurse managers the ability to moderate and control delivery of care service, adjusting intensity and cost. Fourth is determining values for the productivity equation, which is output divides by input. In the prospective payment system or PPS, this output measure has been the discharge patient. Fifth is determining quality. Once a standard time element is established, staffing is adjusted to meet the aggregate times. A nurse manager can elect to staff below the standard time to reduce cost. Next is to develop a workable patient classification system. The nurse manager must be determined the following. First, or letter A, is number of categories into which the patients should be divided. Second is the characteristics of patients in each category. Third is the type of the numbers of care procedure that will be needed by a typical patient in each category. And lastly is the time needed to perform these procedures that will be required by a typical patient in each category. So that's all. Thank you.
Good afternoon everyone, I am Melissa Gail Albas and I'm going to talk about the types of patient classification system. There are different kinds of PCS used in administration, but three are most commonly used types, and these are the narrative description, checklist, and time standard or relative value unit. First, we're going to talk about the descriptive type or the narrative. The nurse classifies the patient into a category that most closely describes the care received. The tool used is a narrative on a concise acute table. The major problem with this type of system is low interpreter reliability, caused by subjectivity in the nurse's interpretation of the degree of care required by the patient. The descriptive type is a quick check guide but poor interpreter reliability to a wide range of requests nurse-patient ratio. Second is the checklist. This is a type of acuteness table divides element of care routines into activity categories such as eating and bathing. Activity levels are described in each category. Levels in eating might be self-care, help setting up, feeding, and frequent feeding. Each activity is assigned an activity level point score, such as 1 for routine care or self-care and 4 for comprehensive care. The nurse checks the level of activity for each patient in each category and totals the patient point for each patient to determine the level of care. This is usually done at each shift or daily. It too is a subjective system. Lastly is time standard or relative unit. System assign a value unit, usually a measure of time, to various activities of patient. These activities are usually clustered into categories such as diet, bathing, and mobility. There is considerable variation in complexity of this system. That is all for the types of PCS.
Classification categories. Among these three, most commonly used in the descriptive kind of patient classification system, these are subdivided into four classifications, namely Level 1, self-care or minimal care, Level 2, moderate care or intermediate care, Level 3, total, complete, or intensive care, and Level 4, highly specialized critical care. Level 1, self-care or minimal care. Patient can take bath on his own, feed himself, feed and perform his activities of daily living. Under this category are patients about to discharge, those in non-emergency, newly admitted, do not exhibit unusual symptoms, and require little treatment. Average amount of nursing care hours per patient per day is 1.5. Ratio of professional to non-professional nursing personnel is 55.45. Level 2, moderate care or intermediate care. Patients under this level need some assistance in bathing, feeding, or ambulating for short periods of time. Extreme symptoms of their illness must have subdivided or have not yet appeared. Patients may have slight emotional needs, with vital signs ordered up to 3 times per shift, intravenous fluids or blood transfusions, are semi-conscious and exhibiting some psychological or social problems. Period treatments or observations and instructions. Average nursing care hours per patient per day is 3, and the ratio of professional to non-professional personnel is 60 to 40. Level 3, total, complete, or intensive care. Patients under this category are completely dependent upon the nursing personnel. They are provided complete bath and fed, or may not be unconscious with marked emotional needs. With vital signs more than 3 times per shift, may be on continuous oxygen therapy, and with chest or abdominal tubes. They require close observation at least every 30 minutes for impending hemorrhage with hypo or hypertension and cardiac arrhythmia. The nursing care hours per patient per day is 6, with the professional to non-professional ratio of 65/35. Level 4 or highly specialized critical care. Patients under this level need maximum nursing care with a ratio of 80 professionals to 20 non-professionals. Patients need continuous treatment and observation with many medication, IV piggybacks, vital signs every 15 to 30 minutes, and hourly output.
Hi, my name is Alfat Apuntawil, and I'm going to explain you what is the living tree of nursing. The living tree of nursing theories remain as a guiding principle in the day-to-day nursing practice. Florence Nightingale is represented as a strong and solid trunk of this tree, where she is credited with being the first nursing theorist, and she believed that nurses should be well educated and practice independently. Because of her influence in nursing, other theories were developed, and these serve as the branches of the living tree. Without branches, trees would just be stick useful, but not nearly as useful as the whole living organism that is a tree. The first branch is the interactive model with the Paclou and Henderson. Their theory emphasizes the importance of interpersonal relationship between the nurse and the patient. Without their theory, we cannot establish a good rapport to the patient, and we cannot give the care based on their needs. The second branch is the system model by Newman, Johnson, and Roy. The system model view the person as a multi-dimensional being, and they see the role of the nurse as helping the patient react or adopt in a healthy way to its continually changing environment. Of course, they also believe that there are internal and external stressors that influences a person. As a nurse, we need to evaluate these stressors so that we cannot respond appropriately in assisting the person to a continuum of health. The third branch is the developmental model by Watson's, Leininger, and Roger. This model makes an assumption that there is a process of growth and maturation that is directional and has some orderly purpose. Changes are intersync, predictable at each point at growth, and have some causal factors. The cause can be natural method that is needed in the development of growth or an environmental factor.
The four meta-paradigms of nursing. The roots of these three are the four meta-paradigms: the person, environment, health, and the nurse. They represent a worldview of common concepts in nursing. Florence Nightingale and her concept of caring for the whole person, body, mind, and spirit, with caring as the essential component of nursing, aligns with the daily nursing practice of caring for patients. The four meta-paradigms are defined as follows. First is the person. This is the individual with whom the nurse is interacting in a therapeutic manner. The relationship may include more than one person. The nurse may also interact with small groups such as family or even larger groups as in public health. In some settings, this person who is the recipient of the care may be identified as a patient or client. Next is the environment. Environment encompasses any place where the therapeutic interaction occurs. The environment is not exclusive to the hospital setting. It may be freestanding clinics, nursing homes, schools, corporations, or homes. The third is the health. Traditionally, health was described as the absence of disease. As nursing has progressed, nursing has viewed health as a continuum, according to Catalano in the year 1996. Health can be defined as the optimal level of one's potential relating to the environment. If a person with a disability has adapted and is functioning normally, that person would be considered healthy. And the last is nursing. The profession of nursing uses assessment, nursing diagnosis, care planning, intervention, and evaluation in the care of the person. Especially in these times, the nurse is not only responsible for the physical care of the person, but also has an intricate relationship with him or her. Incorporating all aspects of the person, the nurse develops a plan of care and becomes actively involved in educating and interacting with him or her. In conclusion, nursing theory is important for the continued growth and development of nursing practice. Nursing theories enhance understanding of the principles, values, and meanings of nursing profession. They serve to guide assessment, intervention, and evaluation of nursing care. Nursing theory assists nurses to describe, explain, and predict everyday experiences. The benefits of having a defined body of theory in nursing include better patient care, enhanced professional status for nurses, improved communication between nurses, and guidance for research and education.